This lesson focuses on the male patient with urinary retention. Throughout the presentation, you will discover what urinary retention is, causes of urinary retention in male patients, assessing the patient presenting with urinary retention, associated diagnostic testing for various causes of urinary retention, and treatments. At the end of the presentation concludes with a clinical scenario of a male patient presenting to the ED with urinary retention. There are several objectives and goals for this lesson. Your objectives include using critical thinking skills to formulate an understanding of the manifestations, complications, interdisciplinary care, and nursing care of clients with alterations in the urinary system. To evaluate various pharmacological therapies used to treat clients with alterations in the urinary system. To analyze the various surgical procedures and treatment options for clients with alterations in the urinary system, and to provide care of the client with commonly occurring urinary tract disorders. Learning goals consist of communication, employing therapeutic communication skills with clients and other healthcare team members while effectively utilizing various forms of advanced technology in the healthcare setting. Critical thinking, demonstrate critical thinking and problem-solving skills while integrating ethical and legal concepts in the management and delegation of client care. The nursing process, utilize proficient assessment skills in the nursing process supported by evidence-based practice in the provision and management of safe, culturally sensitive care. And lastly, patient-centeredness. Apply principles of teaching, learning to identify learning needs and promote appropriate teaching strategies among diverse populations. Urinary retention is the inability to voluntarily urinate. Acute urinary retention is a sudden and often painful inability to void despite having a full bladder. Chronic urinary retention is painless and is associated with an increased volume of residual urine. Patients with urinary retention can present with a complete lack of voiding, incomplete bladder emptying, or either overflow incontinence. Complications can include infection and renal failure. Causes are numerous and can be classified as either obstructive, infectious and inflammatory, pharmacological, neurological, or other. The most common obstructive cause of urinary retention in men over 50 years of age is benign prostatic hyperplasia. This is enlargement of the prostate gland caused by a benign overgrowth of chiefly glandular tissue and tends to obstruct urination by constricting the urethra. It is also known as BPH. In a 2000 study on acute urinary retention by Chung and Eberton, out of 310 men over a 2-year period, 53% of these men had urinary retention caused by BPH. In obstructive urinary retention, the obstruction may be intrinsic, such as prostatic enlargement, bladder stones, or urethral stricture, or extrinsic, such as when a uterine or gastrointestinal mass compresses the bladder neck, causing outlet obstruction. Other common causes of urinary retention include prostatitis, cystitis, urethritis. Acute prostatitis, the most common of the three, is usually caused by gram-negative organisms such as Escherichia coli and Proteus species, and it results in swelling of the acutely inflamed gland. Urethritis from a urinary tract infection, or UTI, or from a sexually transmitted infection can cause urethral edema with resultant urinary retention. Genital herpes may cause urinary retention from local inflammation and sacral nerve involvement, a condition known as Ellsberg syndrome. Medications with anticholinergic properties such as tricyclic antidepressants, Elavil, Sinequin, cause urinary retention by decreasing bladder detrusor muscle contraction. In a 2005 published population-based study, non-steroidal anti-inflammatory drugs and increased risk of acute urinary retention by Verham, Dielman, and Van Wink found that men using non-steroidal anti-inflammatory drugs, referred to as NSAIDs, such as ibuprofen and Aleve, were twice as likely to experience acute urinary retention compared with those not using these agents. NSAID-induced urinary retention is thought to occur by inhibition of prostaglandin-mediated detrusor muscle contraction. Neurogenic or neuropathic bladder is defined as any defective functioning of the bladder caused by impaired innervation. Normal functioning of the bladder and lower urinary tract depends on a complex interaction between our brain, autonomic nervous system, and somatic nerves that supply the bladder and urethra. Interruption along these pathways can result in urinary retention of a neurologic etiology. Most of the patients with neurogenic bladder will experience incontinence, but a significant number might also experience urinary retention. Up to 56% of patients who have suffered a stroke experience urinary retention, primarily because of detrusor hyporeflexia, with the majority having resolution in about 3 months. In multiple sclerosis, voiding dysfunction tends to correlate with the severity of the multiple sclerosis, with urinary retention being present in approximately 20%. Up to 45% of patients with diabetes mellitus and 75 to 100% of patients with diabetic peripheral neuropathy will experience bladder dysfunction, and this is likely to include urinary retention. Disc herniation, spinal traumas, cord compression from benign or malignant tumors may cause urinary retention through interruption of spinal pathways in our nervous system. If neurogenic bladder is suspected, patients can present with overflow incontinence or a recurrent UTI. A history of neurological disease, spinal trauma, or tumor, diabetes, and any change in baseline neurological status should be carefully noted. Patients with suspected neurogenic bladder should undergo a general neurological examination, as well as specific examinations related to their bladder function. These can include the bulbocavernosus reflex, which is a contraction of the bulbocavernosus muscle when the glans penis is squeezed. An anal reflex test. This consists of contraction of the anal sphincter when the surrounding skin is stroked. Voluntary contractions of the pelvic floor. Anal sphincter tone and sensation in the S2 to S5 dermatomal distribution, which is in the perianal and saddle area. Imaging studies looking for tumors or other lesions in the brain and spinal cord may also be indicated. The bulbocavernosus reflex test is performed by placing the index finger of the non-dominant hand on the anus while squeezing the glans penis or tugging on an indwelling Foley catheter and monitoring for contraction of the anal sphincter. If contraction is present, there is no indication of spinal shock. If contraction is not present, this indicates the presence of spinal shock. The anal reflex test is similar to the bulbocavernosus reflex test. You use a non-lubricated finger to gently scratch the skin surrounding the patient's anus and observe for sphincter contraction. To test for voluntary contractions of the pelvic floor, ask the patient to cough. Coughing provokes stress urinary incontinence, and therefore voluntary coughs are used clinically to assess pelvic floor dysfunction. The anal sphincter tone can be determined during the digital rectal exam. To test for sensation in the S2 to S5 dermatomal distribution, use a non-lubricated finger or a cotton swab. Gently touch the perianal region in a dermatomal pattern and ask the patient to identify when you contact his skin. Imaging studies looking for tumors or other lesions in the brain and spinal cord may also be necessary. Once neurogenic bladder is diagnosed, your patient should be referred for urodynamic testing to guide ongoing management. Patients with chronic urinary retention for neurogenic bladder, bladder dysfunction, either flaccid or spastic, caused by neurological damage, should be able to manage their condition with clean, intermittent self-catheterization. Low friction catheters have shown benefit with these patients. The history of present illness will generally reveal a history of multiple lower urinary tract voiding symptoms, including frequency, urgency, nocturia, straining to void, a weak urinary stream, hesitancy, sensations of incomplete bladder emptying, and stopping and starting of the urinary stream. The history may also include previous episodes of catheterization. The healthcare provider should inquire about precipitating factors, including alcohol consumption, recent surgeries, a UTI, genitourinary instrumentation, constipation, large fluid intakes, exposure to cold, or prolonged travel. A detailed medication history should be obtained for prescribed and over-the-counter medications, with special attention being given to those that are known to cause urinary retention as mentioned earlier. Abdominal examination should include percussion and palpation of the bladder. A bladder should be percussible if it contains at least 150 milliliters of urine. It may be palpable with more than 200 milliliters. A rectal examination should be performed to estimate the patient's prostate size and to check for prostate nodules and fecal impaction. Laboratory tests to assist with diagnosing the etiology of a urinary retention may include a urinalysis to evaluate for infection, hematuria, proteinuria, glucosuria, or a serum blood urea nitrogen, creatinine, electrolytes to evaluate for renal failure from lower urinary tract obstruction, a serum blood glucose to evaluate for undiagnosed or uncontrolled diabetes mellitus in neurogenic bladder, a prostate-specific antigen test or PSA, which would be elevated in prostate cancer. It may be elevated in benign prostatic hyperplasia or BPH, in prostatitis, and in the setting of an acute urinary retention situation. Imaging studies may include renal and bladder ultrasonography to measure post-void residual urine, to evaluate for bladder and urethral stones, hydronephrosis, and upper urinary tract disease, a pelvic ultrasonography or CT of the abdomen and pelvis to evaluate for suspected pelvic, abdominal, or retroperitoneal mass or malignancy causing extrinsic bladder neck compression, a MRI or CT of the brain to evaluate for intracranial lesions including tumors, stroke, multiple sclerosis, or an MRI of the spine to evaluate for lumbosacral disc herniation, cauda equina syndrome, spinal tumors, spinal cord compression, and multiple sclerosis. In males with a previous history of urinary retention, upon physical examination, detection of an enlarged, firm, non-tender, non-nodular prostate on digital rectal examination may indicate BPH. If the patient presents with fever, dysuria, which is painful or difficult urination, back, perineal rectal pain, and upon physical examination, the prostate presents tender, warm, and boggy, the indication may be acute prostatitis. Note that a penile discharge may be present as well. A male patient presenting with weight loss, constitutional signs and symptoms such as fevers of unknown origin, hyperhidrosis, generalized hyperhidrosis, chronic pain, fatigue, dyspnea, and malaise, illness or uneasiness whose exact cause is difficult to identify, and upon physical examination by DRE and a large nodular prostate is noted, prostate cancer may be indicated. Management of urinary retention will depend on the etiology and may include surgery, medical treatments, and/or pharmacology. The most common surgery is transurethral resection of the prostate. In this procedure, the urologist uses a tiny tool inserted through a catheter to remove a section of the prostate. This treatment is used frequently for urinary retention caused by BPH. When there is a stricture that cannot be resolved by widening, a urologist can open the stricture with an incision. The procedure, referred to as an internal urethrotomy, is performed via a special catheter inserted into the patient's urethra. If the cause of the urinary retention is a tumor or cancerous tissue in the urethra, bladder, or prostate, removing those tissues may reduce the problem. Bladder drainage is the use of a catheter to drain urine. Acute urinary retention treatment usually starts with catheterization to relieve the distress of a full bladder and to prevent further bladder damage. Urethral dilation is used to treat urethral strictures. This is done by inserting increasingly wider tubes into the urethra or inflating a small balloon at the end of a catheter inside the urethra to widen the stricture and allow an easier flow of urine. Stents are inserted into the urethra to the area of the stricture and may be temporary or permanent. Once stents are in place, they expand like a spring and push back the surrounding tissue, widening the urethra. Men with acute urinary retention from BPH have an increased chance of returning to normal voiding if alpha blockers are started at the time of catheter insertion. Various drugs are used to treat urinary retention and may include Cardura, Cialis, Flomax. Standard transurethral catheters are readily available and can usually be easily inserted. If urethral catheterization is unsuccessful or contraindicated, the patient should be referred immediately to a physician trained in advanced catheterization techniques. Because there is no evidence that gradual bladder decompression will decrease complications, rapid and complete emptying of the bladder is recommended. Note that hematuria, hypotension, and post-obstructive diuresis are potential complications of rapid decompression. For hospitalized patients requiring catheterization for 14 days or less, silver alloy impregnated urethral catheters have been associated with a decreased rate of UTI versus a standard catheter. Patients requiring catheterization for up to 14 days experience less discomfort, bacteriuria, and need for recatheterization when suprapubic catheters were used compared with urethral catheters. In a 2006 study, a meta-analysis comparing suprapubic and transurethral catheterization for bladder drainage after abdominal surgery by McPhail, Abuhilal, and Johnson, suprapubic catheters were found to decrease bacteriuria and discomfort and were preferred by the patients. The use of silver alloy impregnated and suprapubic catheters remains controversial, although evidence does suggest a short-term benefit. With all that being said, let's look at a clinical scenario. You're working in the emergency department when MB, a 72-year-old man, enters with the chief complaint of inability to void. His initial vital signs are blood pressure 168/92, heart rate 70, respirations 20, and temperature 98.2 degrees Fahrenheit. While you are taking Mr. MB's history, he tells you he is generally in good health and leads an active life. His current medications include Proscar, 5 milligrams a day, and vitamin supplements. He reports that he has been unable to void for 12 hours and is very uncomfortable. He asks you to help him. Given MB's chief complaint, what would you expect to find during your initial assessment? What are your priorities for this patient? After examining MB, the emergency physician asks you to insert an indwelling urethral Foley catheter. What should you include in MB's teaching before placing the Foley? The ED physician writes orders to discharge MB with instructions to see his primary care provider the following day. It is your responsibility to give discharge instructions. Now outline your care plan.